Good morning, ladies and gentlemen. It's an honor to be here in this prestigious institute where a man like Professor Barua, I know him. He may not be knowing me. I know him. He's a famous neurosurgeon. I was in Calcutta for many years in Army Hospital, so I know him. My own colleagues, I'm really grateful to them who remembered me. When he became chairman, Nazrul, he remembered me. And when he became APLAR president, Atikul Haq, he remembered me. Otherwise, as you grow up, probably try to forget a retired person. I'm a retired Lieutenant General from Indian Army. I served for 40 years. And after serving for almost 40 years, I joined. First, I was in this hospital. This is something like, I don't know, not many Indians also knows what about the other people. This is an Army Hospital Referral and Research, which is something like a Walter Reed Hospital, most heavily funded hospital. That's why I could establish a rheumatology department. This whole floor was way back in 1995 with everything on earth, which probably not many, even a European departments can boost off. We had a flow cytometer, we had everything, whatever a rheumatology department had. So that was the journey from this hospital. And once I left the uniform, I joined another hospital, which is Gangaram Hospital. So I'm presently in Gangaram Hospital. I'm grateful to Atik. This picture was probably taken and he had sent me in the morning, so I just included in this. I wanted another picture with Atik. He is our president, but I somehow could not load it. So he's, today not many people, look, you have 40 medical college. That is almost 40 medical college. You have 40 rheumatologists. Let's have one rheumatologist everywhere. You have such a big name internationally. I can tell you when Atik and Nazrul, when they sit on those international forum, and it's a big name for Bangladesh. So if you have such a big international name, your vice chancellor is here, he's supporting you. Let's have a rheumatology department in other colleges also. So if you teach your students, they will be benefited. So that is my dream. In 1991, I was a physician with about 10, 12 years of service in Army. I joined. And believe me, there was nothing in rheumatology. All other specialty, whether you talk about neurology, neurosurgery, has echocardiography, endoscopy, and probably we didn't have much, but we learned this clinical science, which we call it last bastion of the clinicians. We knew it's a clinical specialty. You just require a table and chair, and you can diagnose rheumatoid arthritis, lupus, systemic sclerosis. So we learned, but from 1991, now the story is different. 1991, this was a diagnosis of rheumatoid arthritis. Even painter can diagnose this. Advanced disease, which probably nothing much to do. We also learn that there are many types of arthritis. I'm very sure this is a mixed crowd. It's not a rheumatologist crowd in APLAR or that. There are different diseases. Some diseases can affect the synovium, and that is my topic today. They are synovial diseases. The main onslaught is on synovium, then probably the disease is rheumatoid arthritis. If main onslaught is on tendon and ligaments, that is a different disease, a differently treated also, and that is spondyloarthropathy, or popularly called as ankylosing spondylitis, a disease which at my age or elderly people has, like our ex-Prime Minister Atal Bihari Vajpayee had. The main onslaught in the all what we call it neurology, the level of lesion. The level of lesion is cartilage. So there are different level of lesion. Do you have pointer with you? So if there are different level of lesion, then there are different diseases. That is how the research is done. And we learn that I call it painful paralysis. I can tell you a lot of people feel that what is so great in rheumatology. We have seen my mother was paralytic. But when I see rheumatoid arthritis, I call it painful paralysis. And we learn over a period of time that yes, except probably autoantibodies, probably not much is happening in rheumatology. We developed ultrasound, believe me, much before European country, I attended first Europe ultrasound workshop. We created, because we were sure, way back in 2003, in Army Hospital, with the help of IIT, I got a joint probe, and we call it joint probe. We didn't call it the ultrasound machine. We called joint probe, and we started doing ultrasound for one condition only, which is very popular in rheumatology, called Baker's cyst. And over a period of time, see how the ultrasound has developed. We were doing for 10, 12 years. That is how it has developed. And we also started diagnosing it, rheumatoid arthritis, early. That is, so today, the diagnosis, like you diagnose the rheumatoid, you diagnose myocardial infarction early. You diagnose brain tumor early. Earlier, brain tumor means vomiting, projectile vomiting. We don't have that kind of thing. Same as rheumatoid arthritis. Because of the ultrasound, we can diagnose early. And of course, this was, which he was talking, Nazrul, arthroscopy. We did a lot of synovial biopsy. And we were discussing about what is... Now, coming to rheumatoid arthritis, we know it's an inflammation. So if it's an inflammation, you require anti-inflammatory drug, so nothing great about it. It's an immune inflammation. It is treated by the... then, beside anti-inflammatory drugs, you have some anti-inflammatory drug. And of course, we use steroid, and we use physiotherapy. But we must tell you, the people who are sitting behind, that it's a medical emergency. The moment you diagnose rheumatoid arthritis, you must send to a correct person. Why it is medical emergency? Because that is a time it is treatable. Sorry. How it is works?
It is the point.
It is the point. So that is the time it works. That is a window of opportunity. Whether you treat by Tofacitinib, you treat by normal drugs, that's why this is a medical emergency, and it should be treated as a medical emergency. And we know now that more aggressively you treat, your outcomes are better. Earlier we used to treat, we'll give first painkiller for 2-3 months, then we'll give little steroid. So we know now it is. Now another photograph I always show about this gentleman, and he was the man who actually he didn't patent it, he made methotrexate. He's Subba Rao from India, and his name is not there in the books because of many issues. But he patented almost 200 drugs, and methotrexate, he made it, Subba Rao. And I came to know much later in a conference in Delhi that he's the one, physician conferences, I met his brother. So now, when you are using all these drugs, things are not simple. Even these disease-modifying drugs, which we call simpler drugs, they have many side effects, and we know that even in low doses, they can cause mucositis, methotrexate can cause nodulosis, it can cause hypersensitivity, it can cause pigmentation. So as a rheumatologist, we learn about this, and this was one work was done by one of the trainee on the hydroxychloroquine, which we feel it is so safe, electroretinogram, not now, but 15-20 years back. A normal electroretinogram looks like this. It looks like Joker's cap. And when you give hydroxychloroquine, this Joker's cap can disappear. And that is how the early changes, and gradually some more people will take up these issues. So even the existing drugs has to be learned nicely, as was told by our Vice Chancellor, that the drugs has to be learned, the side effects, everything has to be learned. So that is the normal doctors. A rheumatologist can write a drug, but monitoring has to be done by many people. We realize hardly 30-40% people may go in a satisfactory remission. I don't want to discuss those issues, what is a satisfactory remission, but we know it, some low disease activity. We know it, there's no treatment for rheumatoid arthritis. So we try to address this issue by a term called as low disease activity. We know it's a low disease activity we try to achieve. But when it fails, then there are other drugs. For this mixed crowd, you must know there are cells which talk to each other. In literally sense, they talk to each other, and it has been photographed. And when they talk to each other, they release lot of cytokines, you can call it hormone, you can call it. So when they, and these hormones, they also talk to each other. And there where we were addressing this issue by targeting these TNF, IL-1, all those cytokines we were targeting. And we learned that probably the TNF is high, so we were targeting TNF in the beginning. And this gentleman, he's Indian, third generation Indian, settled in London. I salute him for who started, the first paper came in Lancet about the use of biologics, the anti-TNF, and rest is the history. Our rheumatologist colleague knows about this. I don't want to discuss in this because I have to discuss about 5 minutes about Tofacitinib. But if I don't discuss this, you will never know why Tofacitinib came. So we thought that time that is the end of the story. Probably we have won the war. The TNF drug will anti-TNF. And since I was in Army Hospital, it was free. We used for 8,000 patients. Each vial used to cost 50,000 rupees, as Professor Atiqul Haq was telling. He was telling it was so costly that we wanted to write for 400 people, but we could only give it to one. But in Army Hospital, we were lucky that fund was available, and we used it. And over a period of time, we realized this was the first patient in 2002 on biologics. And she was one lady of a brigadier's wife. And they came from London, and she has lost both the hip, and she has lost both the knee, multiple joints she has lost, and she was given anti-TNF, and we learned about anti-TNF. Then came multiple other biologics, and we were using roughly about 500 biologics, all sort of, whether you A, B, C, D, we were using it. Many targets were targeted, not only TNF, T cell, B cell, all those which we know it. And probably this only thing this mixed crowd should know, there are a lot of targets, not only TNF, many other targets of cytokine came. And what we learned that if you use the low dose of these probably, and that was our hypothesis, that if you use low dose and then tuberculosis, which was a fear in the Asia, but we did have tuberculosis even then. So we had some tuberculosis, and this was a Colonel Saab who had this, and I thought again tuberculosis. And that time we were learning ultrasound, and he had a swelling in the axilla. So I was learning ultrasound, I put a probe there, and what I found was this, a big lymph node, and we aspirated, and this was lymphoma. So our fear of infection and some other side effects like tuberculosis, miliary tuberculosis, pneumocystis carinii, and skin infections and rash. So we realized, yes, we must learn and we must have a newer drug. So then came the search for an oral effective medicine, and injectable versus oral. Suppose today a oral insulin comes. You tell me what insulin you will take. You will definitely take a oral insulin. Whole world is talking about oral insulin. So we were searching for a drug which is as powerful as the biologics, and maybe a small, less complicated molecule. Why the drug is so costly? There are a lot of biosimilars made in India also and other places of biologics, but they are still costly because to make a large molecule, it is something like this, So you have a large molecule like biologics, and you have a small molecules which we call it JAK inhibitors or Tofacitinib. So small molecule, simple to make, generics are simple to make. So I feel proud that Bangladesh could take the lead. In fact, I had a photograph which I could not download, that one patient of mine was carrying the Tofacitinib, which is made in this country, hardly for 1/40th price. You can imagine, because the price matters to us. The price has to be low because these larger molecules were costly. So then came the Tofacitinib, and advantage was this, injectable versus oral. So you should have an oral drug, that is number one. But oral drugs, most of the disease-modifying drugs, you take methotrexate, take sulfasalazine, leflunomide. If you start today, they will work after 6 to 8 weeks. So we tell our patient, it's going to take time. So we wanted a work which works very rapidly like biologics. So we are searching for a small molecule. We are searching for a drug which is oral. We are searching for a drug. We were searching for a drug which is the rapidly working, and of course has a less tuberculosis and this tight control. If we can achieve that is how the aim is. We call it treat to target. Like you are treating diabetes, you say, okay, glycosylated hemoglobin has to be this much, for less than 5.6 or something. So same thing is happening in rheumatology. What you are treating, you are not treating pain, you are not treating swelling. You want a target, so treat to target was a term used. So that is how it comes. So came Tofacitinib. So Tofacitinib is the first JAK inhibitor. Now what is this JAK we are talking about? It's not a new drug. It is about 6-7 years old, so it's very safe. A lot of studies has been done, short-term, long-term studies has been done. So first thing is safety. It is already there in the European and American market. It is there. And these drugs block the JAK. Now I don't want to bore you what is a JAK, but just remember that they are the enzymes. And where are these enzymes? These enzymes are intracellular. So these enzymes are intracellular, and these enzymes, what happens normally, in normal like you and me, I don't have a rheumatoid arthritis, but I have these enzymes called, these enzymes are kinases. They are called kinases. What happens normally, they start from here. I think this, sorry. Can somebody help me? This pointer, if it works?
Sorry,
This one?
This one.
This one. So this is the, I think probably because of the lot of shining. So no issue. So these enzymes are here, and probably they are called signal transduction. Now I don't want to bore you with the basic science, but normally cytokines come like, I think this is may not work. I think normally cytokines comes and they come to the receptor, and receptors, then there are JAK enzymes. These are kinases, and these kinases are phosphorylated. And once this phosphorylation becomes, and then another, they gets phosphorylated, and probably it is working, but yeah, maybe it's too shiny a screen, that's why it is. In any case, the idea is not to explain many of the phosphorylation issue, but basically this is called as signal transduction. And these kinases, JAK kinases, their phosphorylation is stopped by these drugs, and I'll show you straight away come to that drug, that this is JAK wave pathway signaling, and this is the, sorry, I think this is, yeah. So how these JAK inhibitors works. Now these JAK inhibitors, what they do, they stop this phosphorylation, and subsequent signals are not there. It is something two people are talking and you create a wall in between. So what is happening, those two people cannot talk. So the cytokine comes, it sits on the receptors, it happens normally, but then the phosphorylation of these JAK kinases are not done. These enzymes are not done, and subsequent step like STAT and all those docking and phosphorylation, and then translocation of this STAT to the nucleus does not happen, and so the gene transcription does not occur, and cytokine formation is not there. Now, what is the advantage of this? This is that this Tofacitinib, there are a lot of other JAK inhibitors are coming. If you talk, let's not talk about those JAK inhibitors. When we start a drug, Tofacitinib, which is already there in market for 6-7 years, our first concern is why it is better than other biologics. Now, why it is better than other biologics is because JAK1, where a lot of other cytokines, I'll show you the next slide, that it actually reduces the formation of many cytokines. So one cytokine versus many cytokines. Suppose you are using TNF. TNF is only for one cytokine, there is a tumor necrosis factor. If you're using a drug against IL-1, IL-6, that is against 1. We realize probably rheumatoid arthritis is multiple cytokines are involved. If you use JAK inhibitors like Tofacitinib, probably it may be more advantageous. It probably blocks more JAK1 than JAK2, than JAK3. So basically a JAK1. And what is the advantage? Look, this was I was talking about. Rheumatoid arthritis is not depending, which over a period of time we realize, it's not depending on one cytokine. Many cytokines are involved. If many cytokines are involved, probably you have to use a drug which can address this issue, and that is how the tofacitinibs come. So these are the cytokines. Unfortunately, this is probably this is working, but it's not showing here that these are the JAK inhibitors, and these are the cytokines IL-2, IL-4, IL-7, IL-9, IL-15. So just to remember that multiple cytokines are blocked, and not blocked, probably their production is reduced, and that is the advantage also. The block is not complete, so side effects are low. 1 lakh patients. So you can imagine at 6-7 years, a huge number of patients has been on tofacitinib worldwide. And out of 1 lakh, look, we are also using it, you are also using it, but good scientific studies has been done in 7,000 patients. So it's a huge figure that good studies has been done in 7,000 patients, and it is approved for 80 countries, not one country. So 80 countries it is there, and we have a real world. Look, clinicians are the boss. So if you're using a drug, and if you say drug is good, that drug is good. So it is a real world experience of 5 years. I'll just take 2-3 minutes more and close. Tofacitinib definitely, whether phase 3 study, phase 4 study, and many, they are called oral, the probably oral stat, or I don't want to discuss all those studies, but in every study, it has been found that is definitely works, whether you call it ACR 70, ACR 20, ACR 50, as good as biologics. Now, as I started my journey, that we were searching for a drug, it's not one of those drugs which has come in the market again. We were searching for a drug which is as effective as biologics. So probably this is a drug, and more clinicians will use it. More and more we will learn about this drug. It is already there for 5 years. The moment you start the drug tofacitinib, it starts working in 3 days. Even biologics don't work like this, except for TNF. So it works very fast. That is number one. And ACR 50 response is, ACR 20 response is seen in 1 week, and ACR 50 response in 2 weeks. So to summarize, it is a rapidly acting drug. That is number one. Then, of course, ACR, what I summarize, that ACR 20 response is seen in 1 week, and in 2 weeks, ACR 50 response, and in 3 days, the pain disappears. And of course, this is a basic science. Probably we can skip these 3 slides and then come to tofacitinib, basically head-to-head trial. Now, head-to-head trial with the biologics. Suppose you say it is better than biologics. So let's have a trial with the biologics. So they did a trial with the adalimumab, which is called Humira in States, and they realized it is as good as adalimumab, and it's even better than this thing. Now, this slide describes this only, that it is better than the drug which is so popular in USA, Humira, adalimumab. It is and long-term safety also. It's not only for short-term safety, and we realize in long-term safety also demonstrates sustained clinical efficacy in 96 months. So almost more than 8 years. So it's a big data is available, and side effects are few. If you really ask me, side effect is this. If you're using tofacitinib, you worry about upper respiratory infection. That is number one. Tuberculosis, you don't worry that much. We always take precautions for whenever you're using, even methotrexate, I can tell you. Even when you're using methotrexate, we always take X-ray chest. So you worry, take care of those which you take for biologics. But herpes is the issue. So you must remember, tell the patient also. So herpes can occur, but rare. It's not that everybody is going to get herpes, but you must say, so about tuberculosis also, but less of tuberculosis, thromboembolic events. Now this we must remember about thromboembolism, because that is because of the JAK2 blockage. So because of JAK2 blockage, these drugs can cause thromboembolism. It is also rare, but you must learn about this. If you're using rheumatoid elderly people, look, most of the patients of rheumatoid arthritis are young female. Young female, you've given methotrexate for 5 years, then you have used this. By the time they become old. So when I joined Army and when I joined the rheumatology, a lot of my seniors say, so you must be treating a lot of old people. I say, no, rheumatologist, my 90% patient is young. Believe me, if you go to a rheumatology OPD, out of 190 people are young people between the age of 25 to 35. The elderly arthritis, osteoarthritis, is a benign arthritis. But what we are treating is a more aggressive, life-threatening condition. Yes, the patient also become old. And when they become old, and if you give tofacitinib, you must be a little more careful in the elderly because you can have more infection. And same is in the pregnancy like other. Probably just two slides more. It can be used in psoriasis. I'm very sure our chairman, Nazrul, will be presenting some in psoriasis and ankylosing spondylitis. I have not used in psoriasis, so I don't have data myself. I have used about 30-40 patients tofacitinib. I can say it's not a scientific study. I'm satisfied. Yes, if somebody, a lot of scientific good studies which I presented, we feel that they are as good as biologics, maybe better than biologics, and definitely coming out to be cheaper from a country like Bangladesh. So we are very happy if this can be used by many patients. So it can be used for psoriasis. It can be used for ankylosing spondylitis. That is probably one of the resident is going to present about ankylosing spondylitis. So this is the last slide. To summarize, we have come a long way in rheumatology. I still remember that when I joined rheumatology, a lot of people said, why rheumatology? So we have come a long way. It's a very vibrant specialty today. I was chairman of selection committee, initially in Army, now in one of the committees outside. The toppers are going to rheumatology. I was an average student, I was not a topper. But what is happening now, the new students in India, they are taking rheumatology because of many issues, which is probably, look, the modern medicine became famous, what called allopathy became famous because of infection, Koch's postulate, antibiotics. So there was trump that you could save millions of human beings. Then came that everything cannot be explained by infection. Then came the concept of autoimmunity. So we are the expert of autoimmunity. So we are at the right time, at the right place. So I tell youngsters, please join rheumatology. If you want, you are joining a career which deals with the autoimmunity. So we have come long way in rheumatology. It's it's a lifelong inflammation. So what a pitiable condition. You are dealing with a condition which is a lifelong pain. And I can tell you what is satisfaction if you can treat it. A heart attack, you have a heart attack, pain can be once. You just have pain once in lifetime, maybe twice. But this pain is daily. You ask rheumatologists who are treating it, how satisfying it is. And we know, especially young women, when rheumatoid arthritis, that is the time they are marrying, that is the time husband expectation, in-laws expectation, and the morning they become stiff. And you get so much satisfaction. So we definitely have come a long way. Immune inflammation is addressed. With the existing drug, we have addressed the immune inflammation. But what we could not address is probably the damage. That is number one. We could not address the fatigue. Look, your patient will come, he doesn't have swelling, he does not have tenderness, but he has a lot of pain. And as a rheumatologist, we don't know. So what JAK inhibitors probably are addressing is the pain and fatigue. That is the newer studies are telling that they address the pain and fatigue also. Current era belongs to JAK inhibitors, tofacitinib and related drugs. Thank you, ladies and gentlemen.